Good morning, everybody, and thank you for coming. My name is Rebecca Levin, and I'm the Director of Evaluation and Learning at the McCormick Foundation here in Chicago. The HealthWork Data Alliance came together 10 days ago when it became clear that no one in this country was systematically collecting data right now that was tracking the well-being of frontline healthcare workers and the conditions under which they were working, so that they are protected and as best as possible, and that we can all be better able to use this data to keep them safe and help out those communities that are still preparing for the surge. All of the 20 plus people who have created this initiative that you will hear about momentarily have done so as volunteers. No one has received any compensation for their time and efforts. And I want to give particular thanks to McCormick Foundation for their sponsorship of this initiative, and to Eighth Flight for their tech sponsorship. We need your help to get this survey out to as many people as possible, to as many frontline healthcare workers as possible, so we can do the best job of aggregating these data and learning from it and using it for right now in order to help. So anything that any of you can do, if you have suggestions on how to improve the outreach for this, please let us know. If you have ideas about the survey that you want us to think about in the next iteration of it, please let us know. We have been flying as fast as we can, and it's not the ideal way of putting out a survey and doing this kind of initiative, but every day is critical, and we decided it was better to get this out as fast as we could and do it as well as we could within these time constraints. So now I'd like to introduce Greg Gonsalves, who is an epidemiologist and the co-director of the Yale Law School, Yale School of Public Health, Yale Medical School, Global Health Justice Partnership, and the Collaboration for Research Integrity and Transparency, and is a 2018 MacArthur Fellow. And Greg's going to talk a bit about the Health Worker Data Alliance.
So I think the first thing to say is that we are flying in a data-free zone in the COVID-19 epidemic. I think many of us on this call realize that data that we'd expect the CDC or HHS to collect, from anything on cases to hospitalizations, is not there, let alone what's going on in our hospitals at the coalface of the epidemic. I'm in New Haven, Connecticut, where Yale New Haven Hospital is, and we have very little idea outside of the sort of clinical people working there what's going on, let alone what's going on in other hospitals in the state, what's going on in hospitals in our region, and hospitals across the United States. And so what we're seeing right now is a sort of crowdsourcing revolution that's being born out of necessity to get the data we need to deal with this epidemic and its complications. I think what's interesting about this initiative is that we're looking at the people who are doing the sort of the most dangerous jobs in this epidemic, where we should be actually detailing their mental health, their physical health, the working conditions that they're facing every day as a matter of urgency and necessity, but we don't have that kind of information. And so in talking to Maria and others, I thought it was important to come on today to say that as epidemiologists who love to collect data to understand how epidemics happen and get ended, I think this kind of data is vitally important to understand what happened at the very point of contact between patients and their healthcare workers over the course of the next few months and years. So don't have much more to add, but I think it's a great initiative, and I hope that people sign up to join the sort of large group that's growing across the country to enter their data, which is all going to be protected and anonymized and aggregated. So we can learn more about what's going on to our doctors, our nurses, our physicians' assistants, our techs, and other hospital employees that we depend on to keep us safe and healthy.
Wonderful. Thank you so much, Greg. That was really wonderful for you to kind of come on and be a champion for public health, as you always have been and are. So without further ado, I think it'd be useful to sort of use today and our limited time together to talk through what we've done so far and sort of how the tool functions at present and how we imagine it kind of expanding in the future.
Maria, you should introduce yourself as well.
Oh, yeah. Hi. My name is Maria Demopoulos, and I'm the project director of the Health Worker Data Alliance. As some of you guys may know, this started out of concern for my sister, who is a physician at a hospital, internal medicine physician at a hospital here in Chicago. And it was really sort of reading the way that different countries were treating and tracking physicians and all healthcare workers. And then thinking about this and kind of playing out the numbers of how long before, my sister gets sick or someone else's sister gets sick. And how can we kind of come together and better support these people who are out there every single day doing their best to protect us. So now without further ado, let's take a look at the project. Okay. Okay, so the first thing I want to do is sort of give you a brief orientation into the project. We've kind of laid this out very intuitively. What's the problem? What's the solution? How it works, why it matters, and what's next. I will say one of the things that has been beautiful about this project is how many people have kind of stepped up and given their all and really worked around the clock to make this come together. As Becca said, in the last 10 days, we've built a website, we built the survey tool, and as of today, we launched this on Friday evening, and we so far have participants from Illinois, Indiana, Washington, Pennsylvania, Tennessee, Michigan, Georgia, Washington, Canada, and California. So you can kind of see the immediate need for the tool for healthcare workers, and we'll kind of play in a little bit more. We'll get into the tool and kind of look at what we're collecting. But the first thing to talk through is sort of what problem are we addressing here. So the first problem is exposure. We know that healthcare workers are more than 3 times as likely as the public, as any member of the public, to contract COVID-19. And we also know that long after the curve flattens, they will still continue to have the most significant and prolonged exposure to COVID-19. And we also know that health workers are our most finite resource. So while we can eventually kind of mitigate supply shortages, not to downplay the significance of that, we have kind of a finite trained workforce who we need to understand and protect. The second issue is recognition. So hospitals and public health agencies have done an admirable job in preparing hospitals and preparing healthcare workers to understand and diagnose and treat COVID-19 patients. We also know that there has been a wellspring of initiatives that are public facing to diagnose and work on contact tracing to understand kind of how the public is faring. In that, I think just due to straight capacity constraints, it's been difficult to shine a light on the experience of health workers themselves. As one hospital administrator said to me, it's been a little bit flat-footed in the response to kind of quickly adapt and respond and develop new resources. Another hospital administrator of a network of 17 hospitals said, yeah, we want to do something like this, but frankly, you're a few steps ahead of us. And when you're coming at this as a volunteer, you assume that we'd already been doing this. And it's been a sobering experience to understand that we're doing the absolute best we can, and it is admirable, but there's a dearth of this kind of data, and there's a definite need for it. And then the third sort of problem that we're dealing with is the response. So information, as Greg mentioned, is disjointed across institutions, across the MSA level, at the state level, and nationally. And it's also difficult to strike the balance of maintaining the integrity and the security and privacy of individual health workers, and also the privacy of hospital administrations who are doing their best to respond amid tremendous capacity constraints. So that's sort of what we're facing and where this was born from. What is our sort of solution? Our solution is really simple. It's first to listen. It's first to listen to actual practitioners and develop a practitioner-informed tool. So we reached out to epidemiologists and physicians and nurses across different healthcare occupations and asked them what was most needed. And we developed the idea that we should just come up with a very simple tool to collect their physical health. So really importantly, we do look across occupations. So there are a lot of different people who make a hospital work, and it's not just physicians and nurses, it's also PAs and ancillary staff who are a critical and often overlooked role of this. We also are starting to see the role that inequity plays, not only in the way that diagnosis and the virus spreads, but also in the way that this plays out across healthcare workers themselves. So there's a story there that we think needs to be told. We also think it's important to track their mental health. So we know that it's been suggested that mental health is the next major crisis here. And while we know that mental health workers are feeling anxious and scared, that's not really too insightful. It is important to be able to show that, and it is important to be able to show how those mood assets cluster, and then also to look at frequency and intensity, and then look at that as a point in time snapshot, and then see how that changes over time. So as different cities and as different regions kind of face preparation and surge, and then flattening the curve, to be able to capture those things, and then also equip public health, the broader public health community, policymakers and hospital administrators to understand and respond to that seems helpful. And then the third thing is occupational health. We're calling that occupational health, but what that really means is we know that there are rapidly changing policies around PPE usage and around quarantine regulations. So what sets the criteria for when someone's quarantined and how long they quarantine? If we can start to share, to collect and safely, anonymize and aggregate those and share them out, we can really learn about what's kind of working best and what we can do better. So those are the three sort of basic solutions that we've come up with. We'll talk through sort of how it works, but in essence, this is at present a very simple survey. The survey is HIPAA compliant, it's anonymous. The beauty of this and the elegance of this is in its simplicity. So we don't ask hospital administrators to give us any information or anyone else. We simply share a link with them that they can text out. Anyone can text out to their health workforce, and individuals elect to participate. I think this is the next one. Individuals elect to participate, and then we can share push notifications with them weekly to collect their progress and their feedback week after week. So currently, we've got a beautiful website that launched, healthworkerdata.org. I encourage you guys to go and take a look. It's a simple, safe, secure place for people to record their experiences. It places no undue administrative burden on hospital administrators or policymakers or anyone else, because it requires no systems integration. It's a very light touch. And of course, this is free to participate. Again, I think it's worth noting that this is not a for-profit entity. This is an effort to be useful in a time of need. So that's the survey. The survey is shared. I kind of walked through the way that individuals can elect to participate and administrators can share with their workforce. The key takeaway here is the need for participation at the administrator level. The reason for that is that we can tell you so much more about your workforce if we have, more of your workforce participating. We can tell you with more granularity kind of what's happening up to date, and how it's changing, how that story is changing over time. So every health worker can participate in the survey. That's on our website, healthworkerdata.org/survey. Any health worker can do that, and we do consistency checks to make sure that they're actually consistent responses with what we would expect to see from healthcare workers. But what we really need for this to work well is hospital administrator buy-in, because if we don't have a high enough percentage of your workforce participating, we can still tell you what's happening in aggregate. That data is still useful to the broader public, but we can tell you with less specificity about the story of your workforce in your institution. And then, as kind of suggested, currently the data is aggregated and anonymized, and it can be shared on our website. So there's two basic end users for this. The first is, as we mentioned, hospital administrators. So hospital administrators can receive customized dashboards where information is anonymized and aggregated at the institutional level, and you can see point in time and longitudinal snapshots of how things are changing. And then there's also the public facing area where we can aggregate and anonymize information at the MSA level, the Metropolitan Statistical Area. And once we have broad enough adoption, that's really useful because that's where you can start to see how you compare to similar MSAs according to relevant benchmarks. Importantly, I think one of the beauties of this tool is that both participants, individual participants and individual institutions are kept anonymous, are kept confidential, so that everyone can have a safe space to participate and share their experiences, and not worry that they're kind of being compared or called out or negatively compared to other institutions. So I think that's quite helpful. I want to just quickly, this is really high level data, talk through some of the things that are happening in the survey. And these are results that are shared just sort of today, and we just launched on Friday. So this is very beta. This is not what the final dashboard will look like. We will kind of look at the dashboards in a moment, the prototypes of the dashboards. But you can see we look at physical health and mental health. What's interesting to me is how you start to see how anxious folks are, and that's kind of displayed over and over and over again. We're also starting to see frequency and intensity kind of changing. And this is, again, just launching since Friday, and then the 2 pilot tests that we did in the last 2 weeks. So that's sort of the mental and physical health piece. The next piece is, so we look at PPE, that's personal protective equipment. What I think is important is we look at general shortage. So what personal protective equipment are you facing shortages on now? And we can kind of track that over time and see it. But then we also look at high and low risk aerosolization procedures because we think that that's a piece that matters. So if you're intubating a patient versus if you're in a room where you're treating a patient who is a person under investigation or a confirmed COVID case, that's going to really matter in which PPE you have usage to, and that's where we're seeing stuff kind of change. So it's useful to be able to disaggregate that. I will also say that we're just going to go through some of the high level stuff. We collect much more and much more granular data on all of these things that we can share out anytime, any old time you want to email info@healthworkerdata.org. We're happy to opine. We also look at quarantine policy. We didn't pull up snapshots for this, but we also look at PPE policy. So we want to look at, have you stayed home due to COVID-19 in the last 7 days? That's the survey interval. And we also want to look at it by, did you stay home for positive or confirmed exposure? So positive symptoms or a test. Did you stay home due to exposure without confirmation? Because we know that large swaths of the workforce are having to, stay home and be quarantined for a period of time without having tests or symptom confirmation. So we think that that's pretty useful. And then also, are you practicing telemedicine? Another note on this is we also look by occupation. So where in the hospital are you working? Are you inpatient? Are you outpatient? Are you anesthesia? Are you ICU? In addition to role, are you a physician, a nurse, whatever? And so we can kind of get more granular. And we also look at whether someone treats adults or is adults or pediatrics, because that seems to be relevant as well. Then we also look at your current systems policy if you're exposed to COVID-19. We think that this will be useful, especially as areas prepare for surge, COVID-19 surge, to collect information on how their policies are changing around whether or not they're quarantining for the full 14 days or switching to quarantining for 3 days without symptoms and then returning to work. And we also expect that once we start to collect data on this and ask people how many days have you stayed home, we'll start to see data cluster in specific areas that might be kind of useful. Cool. And then the next thing I'd like to do is just walk you through some of our top line kind of dashboards that we've just put together. So currently you can kind of see how we're collecting data. Some of the ways we're collecting data. Ultimately, these will be in dashboards that will be ready this week to share with the broader public and hospital administrators. So you can look at it and you can say, by survey question, have you experienced any of these? How are you feeling today? And you can see fraction of respondents who are feeling a specific kind of cluster of emotions. And then you can filter by specific participating hospitals and respondent role. And you could also cluster by age. We collect all kind of demographic data. Importantly, all of these identifiers are masked and anonymized, aggregated. So that's kind of helpful. You can also see on the physical side, sort of how things are changing. Similarly, you can collect and kind of compare stuff over time. And then number of days at home. So that's where that one needs a little bit of work still, but we can see how long folks are staying at home, which is kind of helpful. So that's what we hope that things will look like in the future. And by hope, we mean they will look like this week. So ideally, individual administrators can access a password protected portion of the site. At each level of the data, it's protected and secure. So there's never a moment in the data pipeline where it's exposed. That seems important. So the next thing is then, that's sort of the meat and potatoes of samples of what we're collecting. The last thing is sort of, why does it matter? So we know that we need to have rapid visibility into health patterns. We know that we need to be able to see these things in aggregate to share out, but also at the institutional level, and to be able to collect this data as it changes very quickly. We touched on this a little bit earlier, but the idea that we have a safe method for institutions and individuals to participate, so that we're trying to thread the needle of maintaining HIPAA compliance, security, keeping this low touch, but also giving a place to both health workers and institutions to participate without feeling like they're exposed, because we're already starting to see a lot of feedback from health workers, particularly on the mental health piece, about the strain that's put on them. So that's safe methods for institutions and individuals. In aggregate, once we have more people, kind of scale and participate, it's useful to see kind of insights about what's happening, the story as it's unfolding at different places. This can be used to develop best practices. So if you know that a specific kind of PPE policy or quarantine policy is more or less effective than another one, and you can compare that according to specific criteria on population or age or workforce or occupation or other demographic data, that can be useful to inform in real time how you're responding to this. And that's useful not just now and not just as it surges, but also as the curve flattens, and then in case of resurgence. It's really helpful to be able to look backward and say, hey, thank goodness we captured this data and we can respond to it appropriately. And then the last thing is, that knowledge for the future. So perhaps this is, the curve flattens and then it resurges. In the instance of that, we'll be lucky and glad to have this data. And in the best case scenario, if the curve flattens and stays flattened, which we do not have strong data to suggest that will be the case in the short term at least, we understand that something like this is likely to happen again. And in that instance, it is extremely important to be able to capture, understand, and respond to the needs of the people who are out there on the front lines doing the work every day to keep us safe and protected. So that is why we think it matters. In terms of what's next, we're currently in a sort of our 1.0 MVP, minimum viable product, place right now. So the survey is texted out weekly to participants. Hospital administrators who elect in, or any affiliate group who elects in, they need only share a survey link once, and then we can continue to push out notifications to participants who opt in as individuals to participate. And then we're focusing first on institutional dashboards to give people kind of up-to-date information on their workforce. Version 2.0 is the web app. We're having our kickoff meeting today, and we expect that to go live at the end of this week, which would sound Herculean, but everything we've done so far has been. So the main kind of add there is there's efficiency of input and capture, so people can kind of do a native interface in entering survey data. and they have a better UI experience, and we capture their profile information without having to ask it more than once, which we do in the survey, but it's a bit more elegant. We also have aggregate dashboards, so we can share all the data across institutions and kind of flesh those out. Those will be on the website in a public area, and then individual administrative dashboards are in a private password secure area. And then version 3.0 is the native app. We are really fortunate to have 8th Flight, a development firm here in Chicago, who has donated the development of both the web and the mobile app, which we are tremendously grateful for. The native app, we'd also like to build in the individual data tracking for participants, because they are the heroes of this story, and they deserve to be able to see and track their own experiences over time. And then kind of more robust analytics and reporting hosted inside the app. So it'll still be hosted through Tableau on the website, but then it kind of securely all housed within a single app and a single homepage. That is the idea. So that's our story. That's our song and dance. With the few minutes we have left, I would like to encourage you all to share this with every health worker, health administrator, policymaker, public health official you've ever met. If you are a health worker, please take the survey at healthworkerdata.org/survey. This is all about uptake and engagement from here on out. So we really need your advocacy. And then I'll open it to the floor in case there are any questions or anyone has any comments or wants to talk through other segments of the project.
Great, Maria. We have already a couple of questions. The first one, is there a goal for the number of total weekly responses?
No, not yet. So first of all, I'm the wrong person to answer that question. The people who would be better equipped to answer that question would be our epidemiologists and our physicians. I think that we would need to have some more information to set baseline data, but I can look into it and kind of respond.
Okay. Thank you. And the second is, are we looking to produce periodic, whether it be weekly, monthly, reports for release to the general public or individual hospital administrators?
Yes, absolutely. So individual hospital administrators can kind of choose the cadence of how quickly they want to receive information. And that will be securely shared with them both via dashboards, and then if they want PDF or kind of static reports, they can have that. The aggregate, so we obviously can't share individual institutional data with the public. That's just kind of a privacy call that we've made. What we can do is aggregate it at the MSA level and share that data with the public, and we do absolutely intend to share that out and push that out. Probably, you know, I'm guessing weekly or every 2 weeks, but that's going to depend on ramp.
Great. Someone asked, is this survey and data an IRB approved study?
That's a really good question. So this is an area where we've spent a lot of time talking with our practitioners, and essentially and legal counsel, a lot of time with legal counsel, because this is individuals, not employees, but individuals who are electing to participate and electing to provide their data. We have not had the need to go through an IRB, and that I think is one of the benefits of this project, is that we don't have to go through hospital integration, and we can collect it this way. So legally, we sort of own and maintain the data, and that is useful.
Great. Does anyone else have any other questions that they want to ask right now?
Okay, I think we're good. Thank you guys all for making the time to come out today. I know this is a scrappy new initiative. Greg, thank you so much for taking the time to come out for this. It's tremendously helpful, so thank you. And yeah, we'll be in touch. Please follow us on social media. The website, well, one last time, is healthworkerdata.org, and we will be in touch.
And Maria, if people want to get in touch with you to talk about the study, how do they do so?
Great question. Email address is info@healthworkerdata.org.
Great. Thank you, everybody. Thank you, Maria, for this amazing effort. And hopefully we are going to have some incredible data that is going to be informing what's going on right now in the crisis, as well as helping us in preparing for the future, as you had said. So thank you so much to everyone for all of your efforts and contributions for this.
Yeah, thank you guys.
Okay.
Bye.
Bye.